Good evening, everybody. This is Dr. Kurt Woeller. I appreciate you joining me on this webinar. We're going to talk tonight about heavy metal toxicity, and I'm going to be specifically discussing it with respects to kids on the autism spectrum. Many of the protocols that you see and the information that you see on this presentation could also be applied to other patients as well. In other situations, whether it's adults or teenagers with other different types of disorders. Also, this presentation was originally developed for physicians and healthcare practitioners. So even though if you're a parent and you're watching this, you may not remember or really care about all the nitty-gritty details as far as specific dosage based on kilogram weight, etc. But I'm going to go through that material because I know this is being recorded. So just you keep that in mind. Maybe it's better just to sort of sit back and listen to things as far as a broader perspective. The presentation is also fairly heavy in traditional chelation therapy or heavy metal detox therapy. So DMPS, EDTA, etc. I do talk a little bit about more natural remedies. But again, this presentation was originally for doctors who are implementing biomedical therapy in a certain time frame at which I have to present it. So, the slides, I think there's 42 slides in this presentation. So it's impossible to get into all the aspects of different detox programs because there's so many, and many times those detox programs are very specific for the individual. So with that, we'll go ahead and get started here. So I'm going to define metal toxicity. We'll talk a little bit about provocative challenge testing and whether that is actually necessary. And then we'll talk about specific traditional therapies, DMSA, DMPS, etc., like I mentioned before. And then we'll cover a little bit towards the end on some alternative options that can be looked at. So the question is defining metal toxicity. And one of the things I've mentioned for many years now is that it's not 100% foolproof. And what I mean by this is that there's no test to actually tell us the actual amount or the absolute amount of heavy metals in our bodies. So many times the implementation of a detoxification program for heavy metals is based on clinical suspicion. We can certainly have a test that may indicate the presence of heavy metals, or certainly by history, but we may not always have a test that says, yes, you absolutely have to do metal detox, or no, you don't have to worry about it. So as I teach doctors all the time, you always have to apply every single test you do clinically to the child or clinically to the patient. So in this particular situation, many times it just makes clinical sense to try some type of metal detoxification profile. Now there is a test called a porphyrin profile. A porphyrin profile comes from Great Plains, actually has a porphyrin profile. There's another company out of France that also provides a porphyrin profile, and there's some other labs too. And what the porphyrin profile attempts to do is to try to identify what I call the toxicity index, the chemical reaction at the cellular level to heavy metals, because these porphyrins is this chain-like reaction in the mitochondria of the cells. The end result biochemically is supposed to be the production of heme. But when we have metal toxins or sometimes chemical toxins, or there are even genetic disorders where these porphyrins are disturbed, albeit those are rare, then the porphyrin profile can be a little bit of a deeper analysis as far as the potential for the presence of heavy metal toxicity at the cellular level. And the vast majority of times that's the case because we're not seeing kids with porphyrias, essentially, that is of genetic origin. So as I mentioned before, there is no test that gives an absolute level of heavy metals stored in our body. We can get an idea about the presence of heavy metals, but not an absolute number. So what about provocative challenge testing? We've heard about this, and provocative challenge testing essentially is we give a chelating agent, i.e. a heavy metal detoxifying medicine or supplement, to try to provoke the body to release a certain amount of heavy metals that we can then measure on a test. And so that's called a provocative challenge. The big question is, do you absolutely need to do a provocative? And the answer is, you really don't. It's not something that has to be done all the time. It's not a bad thing to do because it does give some useful data as far as tracking metal excretion over time, which I'll explain shortly. The issue is, even with provocative testing, with many kids that I've done this with on the spectrum, adults as well, about 20% of the time the provocative challenge test doesn't show a significant amount of metals showing up on the urine assessment. This is just my own personal experience. So 80% of the time it does, but about 20% of the time it doesn't. So when you don't get a positive provocative challenge, does that mean that there isn't heavy metals stored in the body? Does it mean you shouldn't pursue detox therapy? Not necessarily, because sometimes proceeding with what I call a treatment trial, maybe it's a couple months, maybe it's 3 months of trying some detox remedies, is not a bad idea, and oftentimes will bring positive results. Now, one of the things that can happen is repeating hair testing can be a useful way of tracking metal excretion over time. Usually, you're checking hair samples about every 3 to 4 months or so, and maybe that's the only thing you did to actually qualify the presence of heavy metals, is by doing a hair analysis and seeing that heavy metals were present. And so therefore, you can track hair testing over time, and that can be useful, and that can indicate the body is actually slow releasing these heavy metals. But within the greater arena of complementary medicine, provocative challenge testing is really sort of still the gold standard, because it does, if positive, give a good baseline of how much mercury or heavy metals are being excreted on a urine test that can then be tracked over time. One of the critical things that sometimes gets missed with provocative testing is it's always important to get a before sample of urine as well as an after sample. And what I mean by that is you want to be able to collect a baseline urine without any metal detoxifier, because some people are exposed environmentally to heavy metals and may just be excreting it, and you'll assume that if all you did was an after provocative challenge test, that all of those heavy metals are of what was stored in the body, and it could have just been an acute exposure. It doesn't happen very often, but I have seen that happen. So it's very important to get a before and after test when doing a provocative challenge. So what are some things that we can use for provocative testing? DMPS provocative challenge testing done orally is actually very useful. Typically 5 to 10 milligrams per kilogram, about an average of 7.5 milligrams per kilogram, does a very good job. And what I have people do is, if we're going to do this kind of testing, is they empty their bladder first thing in the morning, and then they take all of the capsules of oral DMPS at one time, ideally on an empty stomach if tolerated, if possible. And that's usually 45 minutes, 45 to 60 minutes before breakfast, or if they have to eat, a couple hours after breakfast. So you want to start the provocative challenge with an empty bladder. And then once the DMPS is taken, you collect all the urine for the next 6 hours. Now, a couple rules that I've used for many years is to avoid minerals, things like selenium and molybdenum, etc., that might just be in a multi-mineral supplement, at least 12 hours before the urine test and 6 hours during the urine collection. And then once the urine is all collected, people can start, or kids can restart their mineral supplements without issue. And then, it's a good idea to be keeping yourself hydrated or your child hydrated. And, the general rule, 1/2 to 1 liter of fluid, on the day of the challenge is a good idea, because you certainly, if you're the patient, you want to pee. And if your child's the patient, you want them to pee, because, that's where we're picking up on the metals. Now, you can also do a suppository challenge, and this works, fairly well. It's something I might use more for kids who have a lot of oral sensory issues, difficult to get them to either swallow capsules or take supplements at all. So a suppository challenge can be useful, about a 500 milligram dose max, 5 to 10 milligrams per kilogram. And again, if we're doing suppository DMPS, then we can collect urine for 6 to 8 hours. In this case, if I was doing a suppository challenge, I would generally have the parent or the patient collect urine for at least 8 hours, figuring it's going to take a little bit of time for that suppository to get absorbed and for it to do its thing. The other thing about suppositories is suppositories by nature many times will cause people to have a bowel movement, so this is best done after they've had a bowel movement if possible, because I've had situations where you do a suppository and then the kid poops and the suppository gets wasted. You can also do DMSA as a suppository or oral, and it's the same concept. So, you take it on an empty stomach, collect urine for 6 hours or so, and just basically the same way as DMPS. Now, this is an example of a urine toxic metal test. Long ago, I've had the slide around for quite some time, but it shows a marked excretion of lead and mercury, specifically lead, with respects to an oral DMSA challenge. And DMSA is very good at removing lead and mercury. So sometimes this is what does show up. Now, people often ask me, well, should we do a challenge test with natural remedies? And there's some people out there who advocate doing challenge testing with natural supplements, whether it's NDF plus, cilantro, zeolite, different homeopathic preparations, transdermal chelators, transdermal DMSA or DMPS. In my experience, and this is just me, I've never seen anything come back significantly elevated with doing a challenge test on natural remedies or transdermal. It doesn't mean it couldn't happen, I just don't see it. And so I personally don't bother. If I'm going to do a challenge test, I'm going to go ahead and do it with a specific chelator like DMSA or DMPS. Now, I might put the patient on a natural treatment long-term if that's their preference or the parent's preference, but if we're going to do a challenge test, I'm going to use what I know is going to induce the vast majority of times a good provocative release. So what about some different options when you're talking about oral versus transdermal versus intravenous versus suppository, or maybe just a combination of different forms? And then, of course, we've talked a little bit about provocative testing versus just starting therapy. So let's get into that. Personally, by the way, I don't use the transdermals anymore unless it's the only option we have. Years ago, I did, the transdermal DMPS. I did that for a number of years, and, the results were pretty mixed. I often wonder if some of the kids actually improved just because of the glutathione that was actually in the transdermal. I've done transdermal DMSA, same thing, nothing really miraculous. It wasn't that it was harmful. Some parents reported some positive changes, but not to the same degree that I've gotten either with intravenous or oral chelation. Okay, so let's get in a little bit more with respects to some traditional therapy. So we talk about DMSA and DMPS, which are fairly common. DMPS is available via prescription from various compounding pharmacies throughout the United States. And it has to be compounded. It's not something that you can go buy as a supplement. The downside to it is it can sometimes be 2 to 3 times the cost of DMSA. Now DMSA, it tends to go back and forth. There's a period of time where it can be okay to sell it as a supplement, and then there seems to be a period of time where no, it's not okay to sell it as a supplement, even though some places online still do. You can only get it without a prescription, and then it flips back. Anyway, there seems to be no real rhyme or reason to it. It has been traditionally available as a supplement. That means without a prescription, found online. And so, to find that, you just have to do a general search for DMSA, and there'll be things that'll come up. DMSA can also be available as a traditional prescription. And what I mean by traditional prescription is something that you would get from a common regular pharmacy. And the medication is called Kemet. Comes generally as a 100 milligram pill. You can also get DMSA compounded from a compounding pharmacy at different strengths. So it's available in multiple forms. Let's talk a little bit more about DMPS. So DMPS in the United States is not an FDA-approved medication. However, it's listed with the FDA as a bulk chemical that may be used in pharmacy compounding. And basically what that means is that it's not illegal to use. It just has to be obtained through a compounding pharmacy. It is effective against mercury, lead, arsenic, and other metals. Removes cadmium, although EDTA is likely a better chelator specifically for cadmium. And as from an oral maintenance dose, I generally dose anywhere between 1 to 2 milligrams per kilogram per dose about every 8 hours, usually to start with a 3-day on and 11-day off cycle, and may do that continuously for a couple months. And then I might then, at that point, if the patient's tolerating it well, etc., transition to a 3-day on, 4-day off cycle. But I usually don't start DMPS 3 days on, 4 days off. I like to give it a couple months just to see how somebody's responding. And because to me, chelation therapy, or we should call it heavy metal detoxification therapy, is not a quick process. It's not something that you do just for a couple weeks and say, well, it's not working and give up. It's a process that takes place over time. And as time has gone on, I have become more conservative in my approach to heavy metals and not being so aggressive as we used to be, and just working with the child's body or working with the patient's body to remove these heavy metals over a period of time so that we don't create imbalances as much as possible with respect to minerals or vitamins or yeast issues, etc. Now, DMPS compared to DMSA is absorbed about 40 to 50% compared to DMSA, which is around 20 to 30. DMSA in the United States is FDA approved for the removal of lead in children. Matter of fact, if you go to the physician's desk reference and look up DMSA, they'll actually have a protocol that can be used, and using something like for about 8 hours for 5 days, and then cycling it every 12 hours for a couple weeks. And that is the general recommendation for acute lead poisoning. But of course, there's nothing in the reference material like the physician's desk reference to talk about chronic exposure and how to approach that. So everything is more based on an acute issue. So what do we do if we're suspicious or find evidence of chronic issues over time? One of the older protocols that we used to do was using a 10 milligram per kilogram dose every 8 hours, again, 3 days on, 11 days off, and using that therapy for many months. And the general rule was not to exceed about 2,000 milligrams per dose, which you don't actually ever reach when you're dealing with kids. But there's a dosage range: 10 milligrams per kilogram, 20 milligrams per kilogram, maybe upwards of 30 milligrams per kilogram. Usually in the beginning with any patient I deal with and I'm treating, my philosophy is start low, start slow, and then build up. And in doing so, you generally have less problems, less side effects, less reactions, less yeast issues, etc. The other thing about DMSA is that it can be dosed more frequently, okay? Every 4 hours or so, every 4 hours, excuse me, at a lesser dose, maybe 5 milligrams per kilogram. Some practitioners actually advocate doing a much smaller dose, 1 to 5 milligrams per kilogram, maybe more frequently, every 3 hours. Generally, every 4 to start is very reasonable. So there are many different ways of dosing DMSA, and whether you do it 3 days on, 4 days off to begin, or maybe 3 days on, 11 days off to begin for a couple months, is perfectly acceptable. I generally, in the beginning, would, if it's a child who's maybe really sensitive or has a lot of issues going on, or an adult patient, I might go more conservative, 3 days on, 11 days off. But there have been situations, with kids who've been doing biomedical therapy for a while, their yeast is under control, they're on vitamin supplementation, they've responded positively to biomedical therapy in the past. And in those kind of situations, I've gone right for a 3-day on, 4-day off cycle using low-dose DMSA at 5 milligrams per kilogram per dose, or sometimes even a little bit smaller. Now, for those of you out there who have all the work with respect to lower dose DMSA options, this can work very well too. And I've actually become quite favorable to this approach, doing it even much lower than the 5 milligram. And generally using, a 0.625 to 1.25 milligrams per kilogram, to start off every 4 hours, 3 days on, 4 days off, in kids who've, has shown that they can tend to tolerate, biomedical therapy pretty well. There are even those who advocate starting lower than this. It gets difficult when you're trying to break open a capsule and trying to figure out microscopic, very, very small amount, of the DMSA. So in my experience, 0.625 milligrams per kilogram, by the way, for about a 40-pound child, 45-pound child, you're looking at about 12, 10 to 12, 12.5 milligrams per dose. That's very small, certainly very small compared to where we were many years ago, when we were using, dosages upwards of 100, 150, 200 milligrams. So the question then in this situation would be, do you need to do a challenge test? Personally, I don't do a lot of challenge tests anymore because a lot of the chelation that I do is of the low dose nature, and because I've just found that it's effective, kids respond to it, we don't get the yeast side effect issues, parents like it, it's stretched it over time, we don't have the complexities of creating mineral imbalances, etc., and it's just been well tolerated. So this whole low dose DMSA option actually has become a favorite of mine. So from a challenge testing perspective, that's not something I do a whole lot anymore, but at times I do. And then many times when we're doing the low dose DMSA option, after 2, maybe 4 months, is the consideration to implement something called alpha lipoic acid, which is known to now help start to pull metals out of the central nervous system. And generally looking anywhere between 1/8 to a quarter milligram per pound body weight, with each dose of DMSA, generally to start. So usually, in my experience, I don't start lipoic acid right away. I wait at least a couple months to see how things are going. I have had some parents come to me who started lipoic acid on their own, and I'll work with them by implementing some DMSA that way. But if I'm starting the program, I'm starting with DMSA first and then transitioning into alpha lipoic acid. So the key with this is, and the whole gist of this low dose option, is to take your time. It's not about rushing through. You're not going to many times get more metals out by trying to push your child or push yourself if you're the patient, if your body's not ready for it. So what about absorption of DMSA compared to DMPS? Well, as I mentioned before, DMPS is pretty well absorbed from the gut, about 45–50%, compared to about 20–30% of oral DMSA. But honestly, it really comes down to your child or a patient's gut function, because somebody could have a really messed up gut and not absorb very much at all. So, we can't say that we're getting 30% absorption every single time that we take these. But again, if you think about chelation as a process over time, it's about that. It's being stretched out over time. DMSA, in general, more so than DMPS orally, is going to cause more yeast issues. And because it is less absorbed, more of it's left in the gut, and therefore can be a stimulator to yeast. Don't see that much of a problem anymore because of the very low doses of DMSA that we're using. So it's not as big of a problem as it used to. Some people report and complain of being fatigued, lethargic. Sometimes you get loose stools with DMSA because of its lesser absorption than DMPS. But honestly, that's not to say that DMPS couldn't cause those same issues as well. Luckily, it's not that big of a problem. Okay, so let's transition into testing. So what about just different things to consider with respects to tests? I personally think it is a good idea, if you're going to be doing traditional chelation, and honestly, I can make the case even doing natural chelators, it's a good idea to get some baseline blood work. A complete blood count, liver function, kidney function, metabolic profile, some standard tests, just to have something to compare to. Does that mean that I see toxicity from heavy metal, detoxification? I don't. Do I see big problems with it anymore, causing liver problems or kidney problems? I don't. But I still think it's a good idea, if possible, to have that testing done, and then try and repeat it every couple months if possible too. Again, with the low dose options, it's pretty gentle, pretty straightforward. So we're really not creating a lot of issues. And I don't know why my screen just went out. Okay, good. It came back up. What about blood mineral testing, red blood cell? Again, I think it's a worthwhile thing to have in place if you can get it. Great Plains actually has a red blood cell analysis. It's called a red blood cell metals test. Looks at mineral levels in the blood cells, and you can also assess certain heavy metals off that too. But it's really good for assessing minerals and then guiding your mineral supplementation along with that. And then again, that can be done, because it's a blood test, about every 2 months or so throughout the chelation process. The urine essential elements and these toxic metal tests are mostly used for challenge assessment. Again, if I was going to do a challenge test, I'm always going to get a baseline first and then get a urine sample throughout the challenge to be able to compare the difference, and then redo a urine, every 2 to 3 months. In some cases, I've done urine challenge testing when I was doing intravenous chelation, doing a urine test every month. There have been protocols in the past where people were doing urine testing on a weekly basis. Don't find that people doing that much anymore because it's costly, and honestly, it's not all that necessary. Another option is actually to follow the porphyrin profile. That porphyrin profile, remember, is a urine test that you can get from Great Plains Laboratory, and that can be followed, every 4 to 6 months if the test was actually positive to start with. I've not seen a situation where I've seen a normal porphyrin profile and then through the process of chelation had the porphyrin profile turn out to be positive. So I would only do that if the initial test came back positive. One of the things that I commonly do as a screening test, along with, let's say, an organic acid test or a comprehensive digestive stool analysis, is I like to get a hair analysis from Great Plains and a porphyrin analysis, because I want to look at the metal distribution on the hair test. I'll do something called a counting rule assessment, which gives certain mineral imbalances that can indicate the likelihood of a mineral imbalance problem from heavy metals, and then I'll cross-reference that with a porphyrin test. So I always do that as sort of an initial screen to start the discussion about the importance of doing heavy metal detoxification therapy as far as an overall program biomedically. And then there are other things that you can consider from a testing standpoint, organic acid testing, stool testing, etc., every 3 to 6 months. Okay. So let's talk a little bit about calcium EDTA. It's been around, since the 40s, specifically for lead toxicity. It's been used for over 50 years with respect to intravenous therapy. Calcium EDTA is more effective for lead and mercury detoxification than other forms of EDTA, like magnesium EDTA, sodium EDTA. Think about calcium EDTA when you see elevated aluminum, because DMPS and DMSA, they're not that great at grabbing aluminum, but EDTA does a very good job. EDTA also does a good job at grabbing lead, but it's the preferred, it's the preferred chelators, actually for cadmium. We know that DMPS can grab cadmium too, so there's a lot of cross uses of these chelators. The downside to EDTA is that it's not that well absorbed orally. There are some supplement companies out there that actually sell EDTA powder, and the feeling is that if you take it long enough over a long period of time, and some people advocate taking it for years, that it can help to remove lead from the body. But for the general discussion standpoint, it's not that effective in the short term taken orally. It can also be done as a suppository. EDTA most commonly is done IV. Now, there used to be a suppository called Detoxamine, and it was discontinued by the FDA. There is now a newer suppository called Chelatox, which is a 900 milligram calcium EDTA, has a little bit of B3 and some selenium in it as a suppository. And this is generally taken once a day or once every other day. The nice thing about a suppository is that it bypasses the liver and it gets absorbed directly from the intestinal mucosa down in the rectal area, which is actually a very vascular area. I have on occasion had some kids who got yeast flares from an EDTA suppository. It's not something that traditionally is known really to cause yeast flares, but there have been a few cases. But in the vast majority of times, that's not the case. The nice thing about compounding pharmacies is they can actually make suppositories at different strengths. So you don't necessarily have to be locked in just to a 900 milligram dose. Okay. EDTA and other chelators can be used in conjunction to enhance detoxification. EDTA can also be used in a challenge testing standpoint. That's primarily going to be done through an IV. And then, of course, we know it can also be used as a suppository. One of the things that I did in the past, and this is an option that comes up for some people, if we're doing a suppository, is to actually rotate EDTA and or DMPS for DMSA. And an example, this is just an example, where we might start on a Sunday with DMPS, skip Monday, do Tuesday EDTA, then do EDTA again, and then come back to DMPS. So there's a wide variety of ways to do this. And the idea is, you can use EDTA to get things like cadmium, aluminum, lead. You can use DMPS to go after things like arsenic and mercury, or you might even, intertwine DMSA in that mix as well. The other nice thing about suppositories is glutathione can be added to them, glutathione being a very important antioxidant, and that can have an additive effect. The downside to suppositories is that they're a suppository. Some people don't like doing them, and many kids don't like suppositories either. So all of that has to be taken into consideration. Now, if we start thinking about intravenous chelation, this really is the most powerful way of doing detoxification therapy. It's the most direct because you're bypassing the gut and you're bypassing the liver. You're giving that medicine right into the vein, typically using DMPS and EDTA. These things can also be infused by doing glutathione intravenously. If you've ever tried to do glutathione as an oral supplement or a transdermal supplement, it can be difficult orally because of the taste and the smell. Transdermally is an option. None of them compare, in my experience, to intravenous glutathione. I've seen some amazing results with just IV glutathione from kids becoming more alert, better speech, better comprehension. We know that glutathione IV has been used as a support treatment for Parkinson's, other types of neurological disorders. So it's a nice therapy. The downside to intravenous is you have to find a doctor who does it. You have to travel to a clinic and you have to have an IV. Not always practical because, the doctors who are doing it many times are far and few between. And there's different ways of doing IVs. Weekly, every 2 weeks, once a month, really depends on the tolerance of the patient. When I was doing IVs in my office, I minimally would try and do it at least once a week, minimally twice a week. But then I had people who were traveling quite a distance and really could only do it once a month. Usually, provocative challenge testing, the best results for excretion of metals on these urine tests is found through intravenous chelation. You'll get some pretty good results orally, but nothing works from a provocative challenge standpoint like the IVs. And then, this isn't all that useful, I think, just from a general discussion standpoint, probably more useful for, a doctor who's in clinical practice. But there are some different protocols out there. Generally, how I used to do IVs is I would start with a glutathione IV. That would be my first infusion. And usually it's called a glutathione push, where it's pushed into the vein, usually about a 3 to 4, maybe 5 minute time frame. And so that gets infused first, kind of preload the body with an antioxidant, get that process started. And then we'd follow that up with some calcium EDTA in a second syringe. So, and then that could be then infused slowly as well. And then finally, we would then infuse DMPS in a third IV. And usually we could do that process in, 15 minutes. Seems like a long time. I had some kids in my practice who were little champs. They would sit there in the chair. They'd have their little laptop computer or iPad. They're watching their cartoon or their favorite movie, and the nurse is infusing the IV, and they're doing just fine. So a lot of options there, and everybody's a little bit different as far as the protocol they're going to use, but that's kind of the gist of it. Glutathione, possibly EDTA, and or DMPS used together. Let's wrap up here and talk about some alternative options. And like anything in biomedicine, anything in functional medicine, or anything in traditional medicine, there's a lot of options. And so, I don't have everything listed here. I have things here that I've used in my practice, but I realize that there's a lot of supplements, and there's a lot of websites, and there's a lot of people out there claiming this product does this or that product does that. In my experience, the vast majority of these natural remedies are safe. Some of them are actually very effective. Some of them, I think probably don't work all that well and are quite expensive. So you have to take all that into consideration. I do find that people, specifically kids on the spectrum, actually respond quite well to BioChelate. BioChelate is a low-dose oral suspension of calcium EDTA. It's got a little bit of sodium bicarbonate in it, and that alkalinity of the sodium bicarb actually assists in cadmium detoxification. So we need an alkaline system in order to help get rid of the cadmium. So if you're interested in BioChelate, you can actually read about it from New Beginnings website. Just go into the Detoxification support section and you can read about BioChelate. It's been well tolerated, and actually on New Beginnings website they have a dosing recommendation based on age and weight. So this is a low-dose calcium EDTA, and you might think of this if your child has documented lead, cadmium, elevated aluminum. This would be certainly a good choice from my experience. And then there's a wide variety of other things. Okay, zeolite. There's many people who like zeolite, find that it helps them. Helps with chemical detox, and it's hard to say, how well it does at metal detox. I've never seen anything come out on urine tests that was elevated, but I've had people who took it and felt like their kids got better, and I've had some chemically sensitive patients, adults, who swore by it. So who am I to say it doesn't work? It's not something that I specifically reach for myself, but I'm not opposed to its use. The NDF Plus, that has been something that I have used, and it seems to work pretty well. It seems to be pretty well tolerated. There are a few people who tend to react to chlorella, but because this is a clustered cell colloidal product, it's very well tolerated. So NDF Plus is, I would say, is a useful remedy. It goes along with that company's the Liver Life combination. I don't have something written down specifically for that. You can get all that information actually from the NDF Plus website, but I'd say that works pretty well as a natural remedy. I would probably myself tend to use that over something like zeolite, and that's really only because I have more experience with it. The bottle on the bottom of the slide is clay baths, and when the whole clay bath thing came out, I wondered about it. I had a little bit of skeptical about it, but I had parents over the years who actually did clay baths and swore by it. Really felt like it helped their kids, and I could see it in their kids too, on repeat visits. And I think the clay baths actually work, really pretty well. Even better now is one company that has some nice clay baths. And what I've done typically with the clay baths, and this is really honestly for some of these kids who are really, really sensitive. I will actually start with a clay bath as a way to just kind of gently start that detoxification process. I know that I may eventually get to implementing low-dose DMSA, but I've had kids who are so sensitive they can't even handle, the 10 milligrams of DMSA. It just causes too much instability for them. So the clay bath's a nice option, kind of get it going. You do it for a couple months. Maybe then you start to layer in some BioChelate on top of that. Do that for a couple more months. Again, it's the metal detoxification. It's about doing things gently, doing things safely over a period of time and not rushing into it and trying to do too much too soon. So these are just a couple options. Well, what about supportive therapy? These are important. And we talked about IV glutathione. Again, that's not practical for everybody, and I understand that. Transdermal glutathione works okay. I've prescribed it. I still do. And it works all right. The lipoceutical glutathione, I think, works pretty well. If I had to rank the effectiveness of glutathione supplements, I would certainly put IV glutathione at the top of the list. Second to that would be lipoceutical or the oral suspension glutathione. Below that would be transdermal, and then way below that would be glutathione capsules. I don't use glutathione capsules as a powder because those definitely will aggravate yeast, and they're just not absorbed that effectively. So the lipoceutical glutathione is not a bad option. Be aware that it does have a strong sulfur smell. So it's, you open up the bottle and it smells like rotten eggs. One little trick in giving the lipoceutical glutathione is you can put a couple drops of stevia in it just to give it a little bit of a sweet taste, and that generally is more tolerated. Epsom salt creams or Epsom salt baths is a nice additive or supportive treatment for detox. Not a bad way to go. There are a few people out there who are sensitive to Epsom salt, where they, some kids get hyper on it or get agitated. If that's the case and you know that to be the case with your child, then you don't have to use it. But it is a supportive mechanism with respect to detoxification. Liver support is definitely important. And, liver support, I think, whether you're doing IV, whether you're doing transdermal chelation, which I don't personally do much anymore, but it's still out there, or even if you're doing natural chelation or natural detox, not a bad idea to support liver function. This product on the left called Liver Essence is a combination of different herbal remedies. It does contain a little bit of lipoic acid, does contain some NAC. It has artichoke extract in it too. It's a nice product. I'd probably be more inclined to use that with an adult who is not on the autism spectrum to begin with because you generally tend to see less issues. With a kid on the spectrum, I think it could be useful over time. I'd probably not give it, though, right away. And it's not because it's toxic. It's just because the lipoic acid and the N-acetylcysteine can be a stimulator for yeast, and we know how problematic yeast is with the kids. Milk thistle, that's been, that's a very common remedy. 1 to 2 capsules twice a day is a very reasonable thing to do to just help protect the liver against, toxins that are sort of flowing through the bloodstream. So with most of the kiddos in my practice, I'll go right to the milk thistle. Zinc is important, as well as minerals in general. Most of these chelators will take zinc out of the body, so it's an important thing to supplement for. Zinc picolinate, 1 capsule here for New Beginnings is 50 milligrams. Not a bad place to start with most adults. If you have a child that has a hard time with capsules, you can always go to the liquid zinc. The liquid zinc is a very absorbable form of zinc. 10 drops is 15 milligrams. Well tolerated. Anywhere between 10 to 15 drops a day is generally enough for most kids, 4, 5, 6, 7 years old. If you're doing testing to kind of measure where the levels are, then you could be a little bit more specific. But as a general rule of thumb, if you're doing low-dose DMSA, doing things gently, spreading it out over time, that's a very reasonable place to have them, is between 10 to 15 drops of zinc, because you're always going to get a little bit of zinc too through, general mineral supplement. I've used Chelate Mate for many years. I realize there are a lot of other mineral supplements out there. Chelate Mate was specifically designed to assist in the mineral replenishment for chelation therapy. These are not, the Chelate Mate doesn't chelate heavy metals. It's sort of a chelate mate. It's like the mate, hey mate, of chelation. And it's a good product. It's a bit salty tasting, so it's best hidden, for kids anyway, it's best hidden in like a little bit of citrus juice or like grape juice, these types of things. The thing about Chelate Mate is that it's a really great mineral. It does not contain calcium. So if you're using Chelate Mate and your child is on a gluten casein-free diet, they're not getting any calcium, that does need to be added separately. Okay, so let's wrap this up here, and some final thoughts. What's the most direct way of doing chelation? It's pretty obvious, IV, directly into the blood. But it's not readily available or practical for most people. You can go to oral or suppository. Oral over suppository is going to be more preferred. It's more readily available and generally easier to use and access. Transdermal, the transdermal DMSA, the transdermal DMPS, it's still an option. I haven't taken it off my option list. It's just that I generally don't need to use it anymore because most kids, even really sensitive kids, after a while will even tolerate the really low-dose DMSA option. But if we had to, it's still available. But I think it's just, I don't know, weren't really there from my experience in the past. Okay, so with that, I hope that was useful information for you. As always, you can reach me through my biomedical information website at autismactionplan.com if you have further questions, ongoing questions with respects to this topic, or any other topic related to biomedical intervention for autism. This presentation was recorded. It will be available on New Beginnings website for a period of time. You can, if you would like copies of this slide, of these slides, you can contact my office. We sell these presentations, these slide presentations, for $15, and what you actually get is a color PDF. So you're basically getting the actual slide on a PDF format in color, like you see here. If that's something that you'd find useful, maybe for future reference, whatever it may be. And you can email my office at info, that's I-N-F-O, at mysunrisecenter.com. If you ever want to access any of my information and you're not quite, because I've got a number of different websites, you can always go to Dr. Woeller, that's Dr. Woeller, W-O-E-L-L-E-R.com, drwoeller.com, and you can reference my office, and you can reference many of my other websites from that main central website. So with that, everybody, I hope this was helpful for you, and we will talk to you again soon, next month. Take care.